सो हेलो गाइज, आज हम डिस्कस करने वाले हैं हेड ट्रॉमा. सो बिफोर स्टार्टिंग आई वुड लाइक टू थैंक एंड हैव ग्रैटिट्यूड टू ऑल द टीचर्स, parents and God for helping me achieve my goals. So we'll just pray for 2 minutes. So last time we had discussed basics of trauma, and today we'll be discussing about head trauma. So before starting, we'll just quickly go through some flowcharts that we had missed last time, that were the basics of trauma. In the basics of trauma, also I have uploaded some images which you can just go through related to basics of trauma. So let's get started. So first we'll check if there is any obvious bleeding, so we have to control that. Then we'll check the vital signs and the local consciousness, level of consciousness of that patient, that we'll assess by Glasgow Coma scale, that is RTS score, that is respiratory rate, then blood pressure and revised trauma score, RTS, respiratory rate, blood pressure and Glasgow Coma scale. So if Glasgow Coma scale is less than 13, BP is less than 90, or respiratory rate is less than 10 or more than 29. So in these cases, we have to shift immediately the patient to transport the patient to the trauma center, because that is important. The patient is not well. Then we'll assess the anatomic, whether the patient is injured in specific regions, like if there is any penetrating injury in any of the region, could be head, neck, torso or extremity. Then we have to shift the patient. If the chest wall is unstable, like flail chest, we'll discuss in detail what is flail chest. So any chest wall injury or two or more long bone fracture, crushed, degloved or mangled pulseless extremity, upper limb or lower limb, amputation, loss of limb, pelvic fracture, suspected pelvic fracture, then open or depressed skull fracture or paralysis. Any these, then we have to again shift the patient urgently to the trauma center. Then we'll assess the mechanism of injury. So how the patient has injured, whether there was fall. So if it's a children, if the height was more than 10 feet, in adults it is more than 20 feet, or there was some intrusion, like the patient was intruded from the roof in case of vehicle, or there was ejection from the vehicle, death in the same compartment of vehicle, or some vehicle with high injury mechanism, or it is due to some auto versus pedestrian, cycle vehicle crash or motorcycle crash with high speed. If that is also not there, then we'll consider the systemic or comorbidity condition, like whether the patient was old, like the injury of risk and death is more after 55 years, BP is less than 110 in 65 years, even that will represent shock, and low impact mechanism like fall while walking, even that might result in severe injury. Children should be taken care of. Patients who are on anticoagulant, so they will have bleeding risk, so they should be taken care of. Burns, even they will need some assessment and evaluation, so burns patient. Pregnancy patient, so if these patient, then we have to consider that we have to transport the patient immediately to the trauma center. So once we have our patient in trauma center, we'll again just go through the vitals. Before that, again the hemorrhage part, then we'll go for the ABCD, that is airway, breathing, circulation. So we'll again assess the airway, we'll check for the verbal response and GCS, protect the cervical spine if it is not protected already. If there is any risk in that, we'll consider securing the airway. That we can do with help of endotracheal intubation. That would be very proper. Otherwise, we can go with Goodell's airway. Goodell's airway, the image of which I have shared in the group. Then other like laryngeal mask airway is also there. Tracheostomy can also be done, or in emergency, cricothyrotomy is also done. So these are the ways where we can secure the airway. Then we'll check for breathing by physical exam, pulse oximetry. If needed, we'll support by oxygen ventilation. It could be invasive, non-invasive. And if required, we can consider tube thoracostomy, that is chest tube insertion in case of severe pneumothorax or hemothorax. So we'll consider chest tube insertion. Then we'll check for circulation, whether the patient is not in shock. So we'll check his pulse, BP and respiratory rate. And if the patient is in shock, we'll secure 2 large caliber IV cannulas and give him fluid challenge, that is 1 to 2 liter of warm crystallide, and start assessing from where he is bleeding. So if there is no obvious, also we'll consider for any compressive element in the heart, that is it could be a tension pneumothorax, massive hemothorax, or a pericardial tamponade where the heart is being constricted, bahar se dab raha hai heart due to collection of blood in the pericardial cavity. If that has been done, then we have to find the cause of bleeding. If it is not found, that we can do by physical examination, checking his chest, abdomen, long bones, and by examination x-rays, that is intrathoracic, that is chest x-ray, AP view, antero-posterior view of chest x-ray, AP view of pelvic x-ray to consider any injury in the chest or in the pelvis fracture. And we can go for E-fast, that is extended fast. If we are suspecting any bleed in the abdomen, also it will confirm in the chest. So if we have any of these, then we can consider whether we need a urgent intervention, then we'll assess that. After that, if the patient is perfusing well, then we'll check for the neurology and the disability, that is the Glasgow Coma Scale, by checking his movement in all the limbs. Apart from that, the verbal and the motor responses, eye responses, we'll check the Glasgow Coma Scale. And lastly, we'll expose the patient, do the proper checking and prevent hypothermia by warm blanket and fluids. We'll do the secondary survey. If needed, some more evaluation, radiographic, that is the whole body CT scan, the blood tests and the urinary gastric catheters as per required. If we have found anything, then we can try to control hemorrhage by various methods like controlling external blood loss, tube thoracostomy, which we have discussed. If there is any fracture of lower limb or upper limb, then we'll splint and stabilize it, support it, then decrease the pelvic instability by putting a pelvic binder, that is decrease pelvic volume wrap. Then if he needs operation, we'll take him to operating room or interventional radiology if required by angiography. So this was the basics of trauma which we had yesterday discussed. Now we'll be seeing the basics of head trauma, rather whole head trauma, not just basics, because these head trauma is a very important topic in surgery and medicine per se, because it is the most common cause of death in adult age group, especially the 20 to 40 age group, and it is the third most common cause of death in the world. So it is important, and the basics we should know. Even if we are MBBS, we should know the basics so that in case of emergency we can handle such situations. So we'll start with head trauma. So it is the most common cause of mortality after trauma. So as we had seen, massive head trauma can cause death within seconds or minutes. So let's get started. So what are the various causes of head injury? So it could be road traffic accident like crash, vehicle, accident with a bike and cycle, etc. Fall from height, assault, personal violence, or high impact sports like boxing or hitting a ball, cricket ball, even that can cause head trauma. So now we'll just classify head injuries so that understanding becomes easy. So we'll go from out to in. So outside we have scalp. So scalp injury, it could be a closed injury where there is no blood, just a contusion like bruising or something like that, or there could be hematoma or collection of small blood inside which has been secured by the skin itself. Or there could be open injury, scalp injury due to puncture, laceration or avulsion. So we have to take care and manage these cases. We'll discuss the management. Then skull fractures, it could be open or closed, and the fracture can be in the form of linear fracture, comminuted fracture or depressed fracture. According to the anatomy, it could be a vault fracture or a base of skull fracture, that is the basilar fracture. I'm sorry, my computer is malfunctioning today, so there will be some disturbance, but we'll manage. So vault or basilar fractures. So vault is the above part and basilar is the base of skull. So in base of skull, we have three parts, that is the anterior cranial fossa, middle cranial fossa and posterior cranial fossa. So depending on the injury and impact, it will be divided into these. And so this is all about skull fracture. Then coming to traumatic brain injury, in this also we have open and closed. In open we have in these traumatic brain injury, we divide it further. After open and closed, it is divided into diffuse and focal. In diffuse, it can be concussion or diffuse axonal injury. So concussion is where the CT scan is normal, it is just a mild injury where nothing more needs to be done. And like boxing is the common, some of the common cause, like even after fall the initial impact will cause concussion. So concussion is the simplest form of head injury, we can say, where there is no anatomical damage, just sudden jerk to the head. Then we have diffuse axonal injury, which is diffuse and is very bad because it has very poor prognosis and can lead to patient leading to coma, vegetative state. Then we have focal traumatic brain injury, which could be contusion, laceration or hematoma in the brain. And lastly, we have cerebrovascular injury. So any vessel getting injured in the brain area. So this is the last one, that is cerebrovascular injury. So this is the classification of head injury. And now we'll be going into details of head injury. So before starting, we'll just go through the anatomy of scalp. As we know that the scalp has a mnemonic, that is skin, connective tissue, aponeurosis, loose areolar tissue and periosteum. So here, since the skin is very thick, so while suturing we have to use special needle, which we'll discuss. Below skin we have connective tissue, then we have fibrous tissue which connects the aponeurosis to the skin. So in that there are blood vessels. So these blood vessels between these septa are difficult to close or vasoconstrict on case of injury, which causes very high bleeding, very lot of bleeding, high amount of bleeding. So it is very important that we check the patient, and if there is any bleeding, then we have to control it by pressure and by suturing. So scalp laceration, how are these managed? First we have to press if there is any bleeding and control bleeding, and by definitively by doing suture, which is done by non-absorbable suture, which could be silk or nylon. We'll see the suture materials in detail, but for as of now you can just go through with me, like silk and nylon, which is a non-absorbable suture. So always remember that when we are suturing skin, most of the time, 99% of the time, we are using non-absorbable suture. So what is the size of the suture? It is 1, 0 or 1. So one is more thick suture and 10 is slightly thinner suture. And the needle which we use is a cutting needle. Why we use cutting needle? It could be either cutting or reverse cutting, because the skin is thick, and with cutting needle we will be easily able to suture the wound. Because if it is non-cutting like a round body needle, then the suturing is very difficult, and the technique what we use is simple or mattress suture depending on the scenario. Okay, so aponeurosis is the next layer, and bleeding in these subaponeurotic area can cause blackening of eye. Then we have loose areolar tissue which has emissory veins, and if damaged or infected can cause cavernous sinus thrombosis, cavernous sinus which is there besides the pituitary. Then dangerous area of face, so any infection in this area, that is the nose and the upper lip, the nose, lower part of the nose and the upper lip, can cause infection in the cavernous sinus through the retrograde spread. So veins in these area will connect to the cavernous sinus and can spread the infection. And periosteum, which can be affected in case of fracture. So this was all about the scalp and managing scalp laceration, which is the most common type of injury in head injury, among head injury. Then we'll just go through skull fracture. So it could be a non-depressed skull fracture, or a depressed skull fracture, or a base of skull fracture. In non-depressed fracture, we just have to check and monitor the patient. If there is any sign of paralysis or focal neurological deficit, that is focal neurological signs, like the patient is not able to move his limb or some part of his body, if that is there, then we'll need intervention. If that is not there, then we don't need any intervention. It is managed conservatively. In case of depressed skull fracture, if there are some signs of focal neurological deficit, then we have to repair. So, and also in case if the depression is more than the adjacent skull segment, so if it is depressed more than 0.5 to 1 centimeter, then we have to repair it surgically. So how do we do it? We surgically elevate the depressed segment and do dural repair. So this is for depressed skull fracture. Then in case of base of skull fracture, so this is a higher level topic and a complicated topic, but we'll just go through. So how does these present? In anterior cranial fossa fracture, there will be fracture of the cribriform plate from where our nose is connected, and there are olfactory nerves. So how does these present? Clinical features, they will be having raccoon eyes, blackening of eyes due to subaponeurotic bleeding, black eyes, that is subconjunctival hemorrhage in the conjunctiva part. Then trauma will be limited. In case of subconjunctival hemorrhage, in trauma it will be seen up to superior limit. In case of anterior skull base fracture, the superior limit is not visualized. So this is in case of subconjunctival hemorrhage. So if there is fracture, the superior limit of the subconjunctival hemorrhage is not visualized. Okay. So there could be CSF rhinorrhea, like CSF coming through nose, or bleeding from nose, epistaxis, loss of sensation of smell, that is anosmia, and frontal lobe contusion, the part of the brain, frontal lobe, if that is contused or having some injury, then it can give rise to personality or behavioral changes, because that is responsible for our maintaining personality and behavior. So there will be changes in personality. So patient will behave like a psychotic or psychiatric patient. Then coming to middle crania fossa fracture, so it is the petrous part of temporal bone, which is the part of the inner ear. So temporal lobe contusion in the brain, then battle sign, that is discoloration in the mastoid region. This is the mastoid region, which is seen generally after 24 to 48 hours. And hemotympanum, collection of blood in the middle ear. CSF otorrhea, CSF going to the ear and coming out from there. Facial nerve injury, because facial nerve passes through that area. Then paradoxical rhinorrhea. So what happens here is CSF accumulates in the middle ear, coming in the middle ear, then traveling down to the Eustachian tube and then coming through the nose. So from middle ear to eustachian tube to the nasopharynx and nasopharynx through nose. So that is paradoxical rhinorrhea. Then if the patient has CSF rhinorrhea, so how do we differentiate it from epistaxis? That is by the target or halo sign. So here we collect the discharge from the nose on a blotting paper. So if the central circle of the blood, there will be, if there is only one circle that is red, then it is blood. But if we have inner small circle and outer non-bloody circle, inner small bloody circle and outer small non-bloody circle, that is due to CSF. So inner is blood and outer circle is CSF. So if there is two different circles, that is the target sign or halo sign. So we'll have a surrounding halo. And biochemically we can check for beta-2 transferrin, which will be detected in CSF. Then lastly, coming to posterior cranial fossa fractures. That is fracture of the occipital bone. So in the occipital region, there will be visual problem, occipital lobe contusion, sixth nerve injury. Then Wernicke syndrome, that is jugular foramen syndrome, that is due to injury to the 9th to 11th cranial nerve. And these cranial fossa fractures generally are very severe and need support from the neurosurgery team. But initially what is to be done, we start antibiotics, and we should make sure that we do not pack the nose or ear in case of rhinorrhea to avoid anaerobic environment for bacterial growth. So, and many of the times these injuries are so strong that the patient does not survive. So it is very important that if we are suspecting these injury, they should be quickly managed with a neurosurgical team. So now coming to investigation. So what is the investigation of choice? And before that, we'll just go through the NICE guidelines. So if we are suspecting head injury, then we should always suspect cervical spine injury, and we should apply Philadelphia collar, the image of which I have shared in the group. That Philadelphia collar has to be applied as soon as we see a case of spine injury, so that the spine is stabilized until the spine injury is ruled out. So either we can find it by CT or a lateral cervical spine X-ray. So how do we monitor if we are suspecting a patient with head injury? So in the first 4 hours, we check for every half an hour. I think it is first 2 hours. There's a typing mistake. First 2 hours. Then in next 4 hours, we check for every 1 hour. And after 6 hours, we check for every 2 hours. So this is the checking, that is the GCS checking we do in these cases. And how do we, or when do we go for investigation, that is CT scan. So here are the indication which is very important, which is asked commonly. So if the GCS is less than 13, that is one indication. If GCS fails to reach 15 within 2 hours of admission to the hospital, if the patient has loss of consciousness, बेहोश है patient, seizure है, झटका आ रहा है, fit आ रहा है, okay. So if there is more than one episode of vomiting, or there is any ENT bleed from ear, nose or throat, or any focal neurological signs like weakness in any of the limb, then if we are suspecting or the patient is having penetrating injury in the CNS, then even that is a CT scan indication. Then if we are suspecting fracture, then also we have to do CT. And lastly, age more than 65, coagulopathy, where the patient is on some drugs like aspirin, warfarin, which affect the coagulation pathway, dangerous mechanism of injury like fall from height, और patient having retrograde amnesia. So याद नहीं है पहले का कि क्या हुआ था, more than 30 minutes. So these are all the indication of CT. And the last 4 which I have mentioned in the last 4, These are to be done, CT to be done within 8 hours. This is a special criteria, and above most of them are to be done as early as possible within 1 hour. So the last 4 is within 8 hour. In these cases, we have to do in within 8 hour. So as per the NICE guideline, then when should we definitely involve neurosurgeon? When the GCS is less than 8, that is severe head injury. Fall in GCS after admission. So initially GCS was 15, now it has become 13 or 12. Then we should involve a neurosurgeon in the team for managing, rather they only manage. And unexplained confusion of more than 4 hours. In these cases, we should involve a neurosurgeon. Apart from that, in any of the above condition, where we find any of the significant finding, like there is fracture, or there is penetrating injury, or there is some bleeding inside that we have found, then we have to involve a neurosurgeon definitely. Okay, so if the patient has not been injured severely, so what is the discharge criteria in minor and mild head injury? So before that, we'll just go through what is the classification of head injury. I'm sorry. Or we can just like that also we can discuss, because it will. Yeah, it is here only. I was just searching below. So what is the classification of brain injury? So when do we call it mild, minor, mild, moderate and severe? So as we have discussed earlier, that if it is less than 8, then we should involve neurosurgeon. So less than 8 is severe. Then 8 to 9 to 13 is moderate. 13 to 14 with loss of consciousness is mild, and minor is 15 or 15 without loss of consciousness. So this is the classification of brain injury which is asked based on GCS. So based on this, we have some discharge criteria in the minor and mild head injury. So we will discharge the patient when the GCS is 15 by 15 with no focal neurological deficit. CT brain is normal. Then patient is not under influence of any intoxication like alcohol or drugs. Patient has a responsible adult with him, either could be his sibling or a parent or a child. So we have a responsible adult. Then lastly, we have, when we are discharging the patient, we should give a verbal and written advice टू सीक मेडिकल अटेंशन, मतलब हॉस्पिटल कब आना है ये बताना है, ताकि आगे जाके दिक्कत ना हो अपने को भी उनको भी. तो क्या हेडेक, बहुत ज़्यादा हेडेक हो रहा है, परसिस्टिंग वर्सनिंग हेडेक, परसिस्टेंट वॉमिटिंग, बहुत उल्टी हो रहा है, ड्राउजीनेस, बेहोश हो रहा है, दिखाई देने में दिक्कत हो रहा है, विजुअल डिस्टर्बेंस, किसी भी हाथ पैर में वीकनेस या नमनेस आ रहा है. तो ये 5 इंडिकेशन बता के लिख के भेजना है, डिस्चार्ज करना है, ठीक है, डिपेंडिंग ऑन दी अबव क्राइटेरिया. ठीक है. देन कमिंग टू ब्रेन इंजरी. So important aspect is, if there is only brain injury, it will not cause hypovolemic shock. So if there is hypovolemic shock present, so अगर पेशेंट को हेड इंजरी के साथ हाइपोवॉलेमिक शॉक भी है, तो हमको सोचना पड़ेगा कि कहीं और भी ब्लीडिंग है क्या. सो इट कुड बी इन दी फ्लोर. फ्लोर मतलब एक्सटर्नल ब्लीडिंग, कहीं बाहर से ब्लीडिंग हो रहा है जो फ्लोर पे आ जा रहा है. देन अगर वैसा भी नहीं है तो इन दी क्लोज्ड कैविटी लाइक थोरैक्स, एब्डोमेन, पेल्विस और लॉन्ग बोन. सो इसमें कहीं पे ब्लीडिंग है क्या. ठीक है. अगर ये भी कुछ नहीं है और हेड इंजरी के साथ बीपी लो है, शॉक है, तो अब ये भी हो सकता है कि स्पाइनल कॉर्ड इंजरी है. तो स्पाइनल कॉर्ड इंजरी में न्यूरोजेनिक शॉक होता है, ये हमने डिस्कस किया था, क्योंकि सिंपैथेटिक टोन कम हो जाता है. ठीक है. तो ये भी एक कंडीशन हो सकता है, तो सब रूल आउट करना है डिपेंडिंग ऑन द सिनेरियो. देन कमिंग टू ब्रेन इंजरी. तो ब्रेन इंजरी में इट कुड बी प्राइमरी ड्यू टू द इम्पैक्ट ऑफ इंजरी, or it could be secondary due to raised intracranial pressure. Okay, so we'll discuss in detail. So what is primary brain injury? Various types of primary brain injury. So first is concussion, as we have seen that it is the very small form or the mildest form of head injury, where it is generally seen in contact sports like boxing. And we have classification, that is Colorado classification for traumatic concussion, where in type 1 there will be confusion, in type 2 there will be amnesia, and type 3 there will be loss of consciousness. Then in NCCT that is non-contrast CT scan. We do non-contrast CT scan. Okay, always remember in CT head for trauma we always do non-contrast CT. Okay, so that will be normal. So how do we manage? Only rest, take break from contact sports, that will be most probably sufficient. Okay, and what is post concussion syndrome? So repeated injury can cause personality and behavioral changes, that is chronic traumatic encephalopathy. Then we have diffuse axonal injury, which is most severe form of brain injury and has worst prognosis. So what happens here? There is shearing force between gray and white matter. Shearing force between gray and white matter, and clinical presentation is like patient is in full loss of consciousness, that is coma, and GCS is not improving over time. Okay, and CT scan is normal. So how do we go ahead? So the investigation of choice for diffuse axonal injury, that is DAI, is MRI, where we will see punctate hemorrhages, small hemorrhages at the gray and white matter junction, and most commonly the region is corpus callosum. Okay, at that region we will see the punctate hemorrhages. So that will be giving us a picture of diffuse axonal injury. Then what are intraparenchymal injury? So they most commonly occur after trauma, and most common site is temporal region, and secondly is the frontal region. Investigation again is NCCT. So small minor contusion can be managed conservatively. If there is more larger contusion which can increase and cause hemorrhage like picture and cause herniation, so need evacuation. So initially, if it is small, we go for conservative treatment, controlling ICP, which we'll see in detail. And if it is increasing in size or causing more bleeding, then we'll go for surgical evacuation by craniotomy. Okay. Now coming to the next topic, that is type of intracerebral bleed, or what we say, traumatic brain injury, form of traumatic brain injury. So that is extradural hematoma, that is, or extradural hemorrhage. So here, as the name suggests, extradural. So the bleeding is outside the dura. So the bleeding is between the skull and the dura. So extradural, okay, extradural hemorrhage. So how does it occur? So very high velocity impact, mostly due to road traffic accident, and commonly seen in young patient because mostly they are driving fast. And anatomy, most commonly most common region here involved is the temporoparietal region, that this part, and the area is the pterion, which is the H-shaped area where the sutures meet, and just below the pterion is the middle meningeal artery. Middle meningeal artery is there just below the pterion. So this vessel is injured and causes bleeding and the symptoms. So what are the symptoms? So apart from the common symptoms like defect in GCS, what are the other symptoms? Like special is the lucid interval, which we all should know. So initially there will be, here there is a period of normal consciousness. So patient initially will be having loss of consciousness, then he will become normal, then again he will have loss of consciousness or impaired consciousness. So this is due to, so how do we understand this? So initially due to injury there is concussion, and that is causing loss of consciousness, that is just temporary, and later the patient improves, and as the blood goes on collecting inside the brain, he will again have impaired consciousness, that is loss of GCS over time. So there will be a gap of normal period and later he will deteriorate. So impaired consciousness after some time. So this is lucid interval, and it is common, but although not very specific or pathognomic for EDH, it can occur in other head injuries also. Investigation again is NCCT brain, NCCT head. Then how does this appear on CT? As we can see, it is biconvex or lens shaped. We can see biconvex or lens shaped. So we can see biconvex or lens shaped. So important point we have to notice here, that the bleeding here does not cross the suture line. Why does this happen? Why does this not cross the suture line? It is because the dura is connected to the sutures and does not allow the spread of hematoma across the suture line. So therefore they will be limited by the suture. Just a second, I'm just so this was the basic of extradural hematoma or hemorrhage. Now as per the CT finding, we'll go for management. So here what is the management for this is surgery mainly. So craniotomy or burr hole as per the finding of NCCT. So burr hole is done close to pterion, which we have discussed, which is the H-shaped area where the sutures meet, and pterion is the most common site where the EDH occurs because below is the middle meningeal artery. And emergency, in case of emergency, we do burr hole decompression. So the pressure which is increasing inside will get relieved by burr hole. Burr hole is just creating a hole in the skull. Okay, nothing very different, just a hole in the skull. Then indication of craniotomy. What are the indication of craniotomy? So what is craniotomy? Here we create multiple burr holes and remove some part of skull. By joining the burr holes, like we do 3 or 4 burr holes and we join the points of the burr hole and remove the skull and open and remove the clot. So what are the indication? When do we open the skull? So if the clot size is more than 30 centimeter, if the clot size is more than 30 centimeter, 30 cc, so not 30 centimeter, 30 ml, cc is 30 ml, so clot size is more than 30 ml. If there is midline shift, more than 5 mm, so the central part of the brain gets shifted to other side more than 5 mm. Or if the thickness of the EDH, the most longest thickness of the EDH is more than 1.5 centimeter, if the GCS is less than 8, if there is deterioration of GCS during conservative treatment, or in case when there is posterior fossa EDH. So in posterior fossa EDH, in all these indications, also in we have to importantly note that when GCS is less, there is anisocoria, that is difference in the pupillary size. So these are all the indication of craniotomy in EDH. So these are the 6 indication. Just a second. So now we'll just go through what are the steps of craniotomy. It will be interesting for you, that's why I'm telling. So here we open the scalp by incision, and then we do burr hole. Okay, we do the hole, we connect the holes with a mechanical or a what we say, like a driller. It's like a driller. The burr hole and the saw is like a driller. So through the driller machine we do the craniotomy, or it can also be done with jiggly saw. So jiggly saw were used earlier before the invention of the these drillers. So we do burr hole, we connect the burr holes, we remove the skull, part of skull, not the whole skull, the part of skull. Then we evacuate the hematoma, that is collected blood, we remove that. We secure the bleeders. If there is any bleeding, we secure that bleeding. So once the bleeding is controlled, we secure the dura to the bone. So dura is hitched to the bone, and then we again close the bone. And if needed, we can keep the bone in the abdomen for some time if we have to, if there is any chance of rebleeding. So then we can later on fix the skull bone when everything is all right. So these are the main steps of craniotomy which will be helpful to understand. In case you are not able to see a craniotomy in your undergraduate days, it's okay, not a big deal, but you can always see it on internet. Then when NCCT is not available, if you don't have the choice of NCCT, we do the burr hole or craniotomy on the side of dilated pupil. So you have to note that we do the burr hole or craniotomy if we are suspecting EDH in this side of dilated pupil in emergency. Okay, so false localizing sign, we have to note that what is the false localizing sign? It is also known as Carnohan's notch phenomena. So what happens here, although it is not a rule, so in case of left-sided EDH, there will be left-sided pupil dilation. Also it is known as blown pupil. So that's why we do the burr hole on that side itself. Then this will cause, the EDH will cause temporal lobe herniation or uncal herniation. So what is herniation? So the brain getting pushed either to the opposite side or downwards towards the skull opening, that is the foramen magnum, and pressing on the other structure. So what does it do? It presses on the corticospinal tract on the right side, that is the Carnohan's notch, and it causes left-sided hemiparesis. Okay, so it presses the right-sided Carnohan's notch and causes left-sided hemiparesis. So we have to understand that this is just a false localizing sign, also known as Carnohan's notch phenomena, although it is not a rule. Okay, then this was all about EDH. So it is very important topic for undergraduate also and for postgraduate exams also. And basics of head injury. Also, it is very common question asked in postgraduate final year exams in both MS and DNB. Then coming to subdural hematoma. So subdural, as the name suggests, subdural. So it is below the dura and it could be divided into acute, subacute and chronic depending on the time. So less than 3 days is acute, 3 days to 3 weeks is subacute, and more than 3 weeks is chronic. So this can be seen commonly in the chronic one. It's commonly seen in elder patient by severe simple trauma like trivial trauma like fall from bed like that. And here the chances that there is bleeding from the veins. So venous bleeding, that is the cortical bridging veins, these are most commonly involved. Clinical features are generally normal for days to weeks generally in case of chronic one, and acute one due to trauma it could be acute, and after days to weeks there will be altered mental sensorium, so patient will have decreased GCS. And on investigation, how does this appear? So on CT scan it appears like a concave or convex or a crescentic, like a moon, so crescentic hemorrhage, which is white, hemorrhage is white. Try to understand that in the acute scenario, as you have seen above also, in the acute scenario it will be white, this is white. Okay, so biconvex or lens shaped hemorrhage which is seen. So as we have seen here, it was white. So in acute case it is white. So as the time progresses, it will become less white. Okay, and what do we call this? In CT scan we have a term called density. Okay, so density, when it is white we call it hyperdense. Okay, so when in subacute it becomes isodense, so similar to brain. Iso is similar, iso means similar, isomerism. So isodense, so in subacute it will become isodense, which is similar to brain tissue. And in case of chronic subdural hemorrhage, the shape will be same but it will become hypodense, so less dense, so it will become darker than brain, so blackish, it will have a blackish appearance. And in case of acute on chronic, it will have variegated appearance, that is it will be white somewhere, black somewhere, similar to brain tissue. So variegated is variable, so that will be in case of acute on chronic. So that can be asked in future, it is a future NEET question, so just a possibility. Then we generally don't need MRI, it can be diagnosed easily, although MRI is more sensitive for hemorrhage. And small minor injuries, like if the CT scan is normal, even then if you are having high suspicion of injury or the GCS is not good, then we have to go for a MRI to find out whether we have a diffuse axonal injury. So that was important. Okay, so management here again is like craniotomy and remove the hemorrhage. Here we will need craniotomy. Okay, it will not be managed by burr hole because it is not extradural. In extradural, burr hole will help. Here the burr hole will not help. So what is the indication for craniotomy here? So if the thickness is more than 1 centimeter, in EDH it was 1.5 centimeter, here it is 1 centimeter. Again same, more than 0.5 mm midline shift, and any of the any two of the three below. So if there is more than 2 point fall in GCS, raised ICP, fixed dilated pupil, if any of the two is there, then we have to go for craniotomy. Okay, so these are for the acute one. In chronic SDH, what is the, here we go for, initially we go for burr hole followed by craniotomy. So here again this scenario is same if there is more than 1 centimeter thickness or any symptomatic SDH. So in these cases we go for a craniotomy. Now coming to subarachnoid hemorrhage, which we will discuss later again in detail, but just for discussion we'll just have it. So subarachnoid hemorrhage, so as we can understand, so subarachnoid, so in the arachnoid space, so this bleeding is in the arachnoid space. Most common cause for SAH, that is subarachnoid hemorrhage, is again trauma. So the next question which comes is, what is the most common non-traumatic cause of SAH or a spontaneous SAH, non-traumatic or a spontaneous SAH? So it is rupture of berry aneurysm, which is intracranial aneurysm, which forms in the circle of Willis. So berry aneurysm which are formed in the brain. So where does this form? Generally forms in the anterior circulation part, anterior circulation, that is the anterior communicating artery. Anterior circulation, anterior communicating artery, in that part the berry aneurysms are most common, and they can bleed spontaneously. Okay, generally with some risk factors or the size. So most common spontaneous cause of SAH is rupture of berry aneurysm from the anterior communicating artery. Okay, then most of the trauma cases of SAH, they are managed conservatively. Without any surgery, they can be managed. Now coming to the clinical feature, how does this, so especially for the non-traumatic one, in trauma there will be headache due to injury, due to impact. But in non-traumatic, there will be a thunderclap headache. Thunderclap is like worst headache of the life. He has not felt more pain than that. Worst headache of life, thunderclap headache, that is characteristically strained. Then altered mental status, functional neurological deficit, any of these like decreased GCS, or patient having seizures, fits, meningeal signs or symptoms in the form of nuchal rigidity, neck rigidity, or second or third cranial nerve palsy. So these are some clinical features. How does this look? It looks like bright in the fissures and the cistern. This is the diagram for SAH. And if we have it positive, if we are suspecting SH, but if the CT is normal, then we can go for a angio, that is 4 vessel cerebral angio, which is the gold standard for diagnosing aneurysm and arteriovenous malformation. So the 4 vessel cerebral catheter angio, this can be done. So how do we treat? Mainly by conservative treatment, the patient can be managed. But for if there is vasospasm, there we give nimodipine, which is a calcium channel blocker. So vasospasm is due to calcium channel blocker. So we block that calcium channel blocker with help of nimodipine. So that can be used. And here we have a triple H principle, that is hypervolemia, hypertension and hemodilution. So with help of these conservative techniques we manage this. And when do we need intervention? So if the size of aneurysm is more than 7 mm, then we will need intervention. Okay, so if it is possible, like in case of simple aneurysm, we can go for a interventional radiology, that is through endovascular coiling along with stenting or balloon. So just for your knowledge, I'm just telling it that we can do it by interventional radiology under X-ray. So here the technique is endovascular coiling to repair the aneurysm and stenting the blood vessel, or repairing it with help of a balloon. Okay, and if we have to do surgery, open the patient, surgical method, that can be done. So the interventional radiology is not surgical, it is minimal invasive. So we are not opening the patient. Opening means not giving any incision. In surgery, we'll open, that is we'll give the incision and we'll do clipping or excision and anastomosis of the aneurysm. So this clipping and excision is generally done when the coiling is not possible. So this was all about SAH, that is subarachnoid hemorrhage. Then coming to secondary brain injury. So it occurs due to intracranial tension, raised intracranial tension. Apart from that, it can occur also due to hypoxia, hypotension and hypercapnia. So this will cause secondary damage to the brain. So to understand this concept of intracerebral pressure, we have a doctrine, that is Monroe-Kelly doctrine. So what does it state? What does it say? That we can understand this by a very beautiful diagram commonly used. So the skull is a fixed space, like it's a box or a bottle which is fixed, which has four components. It has brain, which is fixed. It has blood, which comes and goes. It has blood, that could be arterial and venous, as we can see in the diagram, and it also has CSF. So if there is any injury or any tumor causing mass effect, like spreading mass, so initially it will compress and cause the CSF and the venous blood to go out. So initially there will be compensation phase. So some amount, there will be signs, there will be symptoms, but patient will be not very badly affected. Like the GCS will not be badly affected. He will not have very severe symptoms. But when the mass goes on increasing, then it will compress the brain. So it will affect the brain, because after certain limit, the blood or CSF cannot be reduced, because it is needed for the normal functioning of the brain also. So if there is after one limit in this fixed cranial cavity, the mass will cause herniation, that is pushing of brain to other area, causing effect in the form of decreased GCS or focal neurological deficit. So here we can see that this mass is causing the brain to go on this side, that is shift in the midline shift. Okay, it is causing midline shift. Also it is known as subfalcine herniation. Subfalcine herniation, where the cingulate gyrus is herniating. This cingulate gyrus, is herniating under the falx cerebri. So subfalcine herniation. Okay, then the second is the midline shift, where here it is shifting to the opposite side. Then third is the uncal herniation or temporal herniation, which is causing at the tentorium cerebelli, and pressing the third cranial nerve. And fourthly is the brainstem, that is central herniation. And fifth is the cerebellar herniation. Tonsil of the cerebellum is herniating, causing brainstem compromise, and it will result in Cushing's triad. So what is Cushing's triad? We'll just see through it. So this was Monro-Kelly doctrine, and after some limit, the brain cannot compensate. So at that stage, there will be raised ICP, and it will show the signs of raised ICP, signs and symptom of raised ICP. We'll see that in detail. So in normal state, the ICP will be normal. In compensated state, the ICP again will be normal, and in elevated state, it will cause raised ICP and cause herniation later on. So what is the clinical features of raised ICP? So what are the clinical features of raised ICP? So it is headache, okay, no, projectile vomiting, okay, difficulty in vision with papillary edema, and cranial nerve palsy, third cranial nerve palsy, okay. So these are some of the signs of raised intracranial pressure. And now we'll be seeing about cerebral perfusion pressure. So what is cerebral perfusion pressure? It is mean arterial pressure, the blood pressure, minus the intracranial pressure. So mean arterial pressure minus the intracerebral pressure. So it should be more than 60 mm of Hg. So cerebral perfusion pressure, so that the brain can function normally, it needs this much pressure so that adequate amount of blood can reach the brain and help in brain functioning. So this much is minimum needed. So when it increases, ICP will increase, then CPP will decrease. So cerebral perfusion will decrease. So to maintain cerebral perfusion pressure, we have to increase mean arterial pressure. So how do we do that? Mean arterial pressure can be increased with help of increasing cardiac output from the heart. And how do we increase cardiac output? We can increase cardiac output by either raising the heart rate or stroke volume. Since the heart rate cannot be raised continuously to a long extent, so the stroke volume is increased with help of increasing the time of diastole. So when we increase the time of diastole, so there will be bradycardia. So bradycardia will increase the diastole volume, diastolic interval. In turn, it will increase the end diastolic volume. That is the volume collected in the chamber, ventricular chamber at the end of diastole, which will decide the amount of stroke volume, and stroke volume will increase heart rate. So there is decreased heart rate which causes increase in stroke volume and will help in maintaining the cerebral perfusion pressure. So this decrease in heart rate is the part of Cushing's reflex. So what is the Cushing's reflex? Due to increased ICP, raised intracerebral pressure, intracranial pressure, intracerebral pressure. So bradycardia, which we have seen now. Apart from that, there will be hypertension, raised BP, and even sometimes hypotension could be there, and altered respiration. So even his breathing will be affected. So there will be altered respiration. Then in case of head injury, there are ulcers in the stomach they are known as Cushing's ulcer. Then how do we manage raised ICP? So to confirm, to diagnose, we'll have the history, the signs and symptom. Apart from that, CT will be showing erosion of lamina dura of dorsum celli. So dorsum celli is the part of the skull area near the just posteriorly near the pituitary fossa. Okay, near the pituitary fossa. So erosion of the lamina dura of the dorsum celli. So dorsum celli is the place where the pituitary rests. So here we will not do lumbar puncture because it can cause herniation and deteriorate. The patient may die. And lastly, we can do is ICP, intracranial pressure monitoring. Intracranial pressure monitoring, that is done with help of external ventricular drain. Okay, external ventricular drain. So we put a drain in the ventricle so that we can control the CSF pressure. So CSF pressure can be controlled and we can decrease the symptom. Or by ventriculostomy, that is done in the lateral horn, lateral ventricle of the brain, in the brain, lateral ventricle, and it has two horns. Either it is done in the lateral horn, frontal horn or occipital horn. F and O, that is frontal or occipital. So in the frontal or occipital horn of the lateral ventricle, we do the ventriculostomy or external ventricular drain is put, or we can put a subarachnoid bolt. Okay, subarachnoid bolt or a intraparenchymal microsensor. These are some advances. So this is the way how we monitor ICP. So now how will we manage? This is very important and it is the basic. So first and foremost, we will elevate the head end of the bed by 30 degree. Give him oxygen, give him fluid. Which fluid we give in head injury? Always remember that we give NS. Okay, so we give NS and nothing else because other fluid can worsen cerebral edema like DNS. Okay, so we should never give anything other than NS mainly. Okay, we have to maintain perfusion pressure more than 100. Okay, avoid hyperglycemia, that is the dextrose solution, dextrose or DNS, which will worsen cerebral edema. If we are having cerebral edema, then we'll give some drugs in the form of mannitol, hypertonic saline, glycerol, lactate and propofol. These will be helping in reducing cerebral edema by hyperosmolar feature, and furosemide and acetazolamide will decrease the production of CSF. So furosemide and acetazolamide will decrease the production of CSF, so it will be helpful for decreasing cerebral edema. Then coming to hyperventilation. Hyperventilation will cause hypocarbia and it will cause vasoconstriction. So vasoconstriction will decrease the symptoms and decrease further bleeding. Then we don't have any role of steroid in head injury. It was earlier used, but now it is not used. So always make a note of that. There is no role in traumatic increase of ICP of steroids. When a steroid is used, so steroids are used in vasogenic edema due to brain tumors. So the cerebral edema is vasogenic in brain tumors. So in that case, we use steroids. Okay. Earlier, we also used barbiturates and hypothermia, which is not now recommended. So you can leave it. And even if after these many intervention we are not able to manage the ICP, then we have to go for an external ventricular drainage or a decompressive surgery by form of burr hole or craniotomy. Okay. So this was all about head injury. Now we'll just go through some updates in the head injury. That is here. Sorry. Here we will try to maintain blood pressure more than 100 in case of patient when the patient is 50 to 70 year of age group, and apart from that we'll try to maintain the BP more than 110. Okay, so 110. So young 15 to 50 and more than 70. These patients will maintain the BP more than 110. Okay, so now we'll be seeing seizure management and prophylaxis for post-trauma seizure. So fits or seizures, or we call mirgi in Hindi. So when do we give or how do we manage these things? So if there is impact seizure, so at the time of injury, there is acute injury to brain, there can be convulsion. Okay. So, or early seizure within 1 week, if there is seizure, then these are early seizure. These will require neuroimaging in the form of MRI to be more precise if we are not finding anything on CT. Then high risk, these patients will have high risk of post-trauma epilepsy, which is a seizure disorder. And in case of active seizure, we will give benzodiazepine like diazepam, okay, diazepam, okay, or midazolam. Okay, these are anticonvulsant. So seizure are also known as convulsion, and this benzodiazepine is a anticonvulsant. Okay, anti-seizure drug or anticonvulsant drug. Okay, so benzodiazepine, BZD is the short form, we call it. Then late seizures after 1 week or generalized in 6 to 18 months or sometimes even single episode, or epilepsy, that is recurrent late seizure after trauma, that can occur. So all these things can occur. So what are the indication for giving this anticonvulsant or anti-seizure medicine? First of all, what are the drugs? So drugs are anticonvulsant drugs like the phenytoin, levetiracetam and carbamazepine. These are the drugs which is commonly given. Phenytoin 100 mg TDS is given for 7 days. So what are the indication? When should we give? So if the GCS was less than 10 with traumatic brain injury, or there is cortical injury in the form of acute SDH, intracerebral hemorrhage, contusion, laceration, SAH. In these cases, depressed skull fracture or parenchymal injury. Okay. In patients having early seizure, especially within 24 hours, patient who are intubated. So when did we intubate our patient? When the GCS was low, less than 8. Post craniotomy, in patient having alcohol abuse or past seizure, even that will increase the risk, and we have to continue anti-epileptic drugs. So these are the indication for where we give anti-seizure medication. So what is the goals of treatment in head injury? So oxygen saturation more than 95, ICP should be 20 to 25, intracranial pressure, then CPP should be more than 60, RBS should be around 180 to 180, BP should be more than 100. In case of young, it should be more than 110, and also in the case of more than 70 years of age group, 110. Then in patient with severe head injury less than 8, we need to intubate the patient as soon as possible. Then we have a Glasgow outcome score. So it is the prognostic score following head injury. So if it is 5, then it is good in recovery, the patient will recover. If the score is 4, it will have moderate disability. In 3, it will have severe disability. 2 will have persistent vegetative state, and 1 is dead. So 2 is persistent vegetative state, also it can be known as coma. Now brain death. So there is no possibility of recovery of brain function here, and it needs 2 doctors to certify brain death. How do we confirm? GCS is 3, pupils are non-reactive, the brainstem reflexes are not there, then there is no spontaneous respiratory effort, ventilatory effort, and there are no confusing factor like alcohol, drug or hypothermia. So in these cases, we will declare brain death, and the patient's body can be used for organ harvesting or organ donation. Now lastly, we'll just quickly go through some indications of head injury where we go for surgery, so that you can remember it better where we need to go for surgery. So in case of open skull fractures, as we have discussed, open skull fracture where the scalp wound communicates with the skull fracture inside. Then depressed skull fracture when the thickness is more than 3 to 10 mm with functional neurological deficit, frontal bone fractures and cosmesis, these indication. Then extradural hematoma, which we have already discussed, which is without considering GCS, that is volume more than 30 cc or ml, more than 15 mm thickness, more than 5 mm midline shift, GCS less than 8 with anisocoria, that is difference in the pupil size, deterioration of GCS during conservative treatment, posterior foci EDH, in subdural hemorrhage more than 10 mm, more than 5 mm midline shift, drop in GCS more than 2 points since injury, time of injury and admission, chronic SDH more than 1 centimeter, any symptomatic SDH. And in intraaxial hematoma or hemorrhagic contusion, like bleeding inside the brain, so volume is more than 30 ml, 5 mm midline shift, which is same. Then temporal or posterior cranial fossa involvement. Then tension pneumocephalus. Pneumo is air. So if there is air inside the brain which is causing tension, increasing pressure, then we have to open up. Then medically refractive ICP. Medically refractive matlab we are giving medication, we are trying to treat by conservative way, but it is not being managed, not able to manage, and patient is deteriorating. So medically refractive raised ICP. So this is also an indication. And lastly, we do not do surgery if the GCS is less than 5, because it is not useful, it is not helpful, it will not help the patient. If the GCS is less than 5, then surgery will not help, it is generally pointless. So we have to definitely assess the clinical situation and then decide, but generally less than 5 the patient is not taken for surgery. Now just going through the flow charts. So if there is a brain injury, we are suspecting brain injury, we go for a CT. If there is some bleeding, we go for a craniotomy with drainage. If there is no bleeding, then we can consider ICP monitoring by ventriculostomy or ventricular drain. We'll measure the ICP. If it is raised, we will raise the head end of bed, give him sedation and pain control, drain CSF by external ventricular drains, mild hyperventilation, mannitol and hypertonic saline and all those things that we have discussed, acetylzolamide, etc., propofol. Okay, so even after that the pressure is not maintaining or being managed, it is refractory, then we will have to go for craniotomy and remove the skull for some time, that is decompressive craniectomy. So here it was craniotomy, where we open and again close the skull, and here it is decompressive craniectomy, where we remove the skull and temporarily keep it in the abdomen until the patient recovers. We can later re-implant it, replace it in the skull. So decompressive craniectomy. So if the ICP is managed or is adequate and is not measured sometimes, we can continue ICU care, monitoring, end organ support, organ system support, manage nutrition, and we can also give antibiotics as per need, prevent DVT and ulcers in the stomach, that is the peptic ulcer disease, and we'll give prophylaxis for that. For DVT, we can use mechanical pump. For ulcers, we can give proton pump inhibitors, PPI. So this will be about basics of head injury. And lastly, we'll just go through quickly the vascular injury. So if we are suspecting brain cerebrovascular injury, okay, so we are suspecting blunt cerebrovascular injury. So injury could be blunt or penetrating, where there is no some metal or some object going inside the body. If it is going, then it is penetrating. If it is not going, just an impact with rest of the body surface normal, then it is blunt injury. So blunt, as we have discussed in the mechanism of injury, so blunt cerebrovascular injury. So if we are suspecting that, or there is some risk factor, we go for a CT angiogram where we see the blood vessel. Okay, if that is positive, then we will differentiate it into 4. Before that, if it is negative, we will stop here. If it is inconclusive, we will repeat CT angio after 24 to 48 hours, or we can do a DSA. What is DSA? It is a digital subtraction angiography. It is digital subtraction angiography. Okay, so DSA, if that is positive, we'll again go for management of these. If it is negative, then we'll stop here. So now, depending on the grade of the injury, cerebrovascular injury, so in grade 1, we'll go for antithrombotic therapy or antiplatelet therapy, antithrombotic therapy with heparin, where we'll maintain the PTT with for of 40 to 50 second antiplatelet therapy, then repeat CT angio or DSA in 7 to 10 days. If improved, normal, injury healed, then we'll stop. If injury persistent, then we'll continue antithrombotic for 3 months, then re-image, and later consider endovascular therapy. So endovascular coiling and all that stuff. Endovascular therapy in the form of stenting, most probably. I'll confirm and let you know. Then in case of grade 2 to 4, we'll go for a endovascular treatment or operation. Okay. If possible by medical management, by anticoagulation, antiplatelet, but mainly as per the condition and the scenario, we'll go mostly with the operative endovascular treatment. Then grade 5, it will definitely need operative or endovascular treatment. So this was all about cerebrovascular injury, and hope it has been understood. And if you have any doubts or any concerns, you can let me know in the comments or messages. You can follow my Telegram channel, that is Pehel Neat PG Free Neat PG Coaching, that is Pehel Free Neat PG Coaching, and you will get the link for the video and the notes there. And you can also join my other Telegram channel for other notes, other topic notes, which you, if you want, especially if you are in final year or doing your post graduation, either MS or DNB. So thank you for watching. Please, if you have liked the video, please like and share and subscribe my channel. And if any doubt, you can comment and let me know. And keep studying, keep growing, and never give up, because great things take time. And see you soon in next video. Most probably we'll be seeing the next topic of maxillofacial injury and neck injury, followed by thorax injury. So this will finish trauma part first in this series. So see you soon in next video. Thank you for watching. Bye bye.